Hello and welcome to the Endometriosis Explained webinar. My name is Sophie and I am the Volunteer Coordinator for Endometriosis UK. We are pleased to be joined today by our guest speakers, Joanne Hanley, Zoe Lapwood, and Elsa Palmer, who will be introducing themselves in just a moment. Before I hand over, I would like to remind viewers that this webinar will have a QA section at the end, where Jo, Elsa, and Zoe will be answering live and pre-submitted questions. If you do have any personalised medical questions, please reach out to your healthcare providers. And without further ado, I will pass on to Jo, Zoe, and Elsa.
Hello, everybody, and good evening. I'm just going to share my slides. Okay, just checking, Sophie. Can you see them?
Yep, we can see those.
Brilliant, thank you. So my name is Joanne Hanley. I'm Specialist Advisor for Endometriosis UK. I also work clinically as an advanced clinical practitioner within an endometriosis centre in the NHS. And then if Elsa and Zoe want to introduce themselves, we can get started with the presentation.
Hello, my name is Elsa Palmer. I work also as a nurse specialist in an NHS hospital.
Yeah, hello everyone, my name's Zoe. I work full-time for Endometriosis UK on the nurse support line, but I have previously worked in a endometriosis centre in the NHS.
Thank you. Okay, so we'll make a start. So, as you are aware, March is Endometriosis Action Month, and our theme this month is Endometriosis Explained. So, endometriosis. It affects 1 in 10 women and those assigned female at birth from puberty to menopause, although the impact may be felt for life. So in the UK, that equates to over 1.5 million, and it can affect anybody from any race and ethnicities are living with this condition. However, so many are still unaware of the condition and its impact. So our aim with Endometriosis Action Month is Endometriosis Explained, exploring both how endometriosis must be better understood by the general public and better explained to patients by all healthcare practitioners. So what is endometriosis? So endometriosis occurs when the cells similar to the ones found in the lining of the womb, which is the uterus, are found elsewhere in the body. And these cells, they can change and grow in response to the hormones within the menstrual cycle. It can create inflammation, cause pain, and lead to scar tissue, so also can be referred to as adhesions. Endometriosis is most commonly found on the lining of the pelvis, which is called the peritoneum, and it may occur in the ovaries, which can cause cysts or endometriomas, and it can also involve other pelvic organs such as the bowel and bladder. Less commonly, endometriosis can be found outside of the pelvis, affecting areas such as the chest, or there are reports. They're quite rare of areas outside the thoracic and pelvic cavity, such as like the abdominal wall or C-section scars. So, just to discuss the different types of endometriosis. So we kind of categorize these into 4 types. The first being peritoneal, which is also referred to as superficial endometriosis. And this is when the endometriosis is found mainly on the pelvic peritoneum. So this is almost like a thin layer that lines the inner surface of the pelvis, and which surrounds the pelvic organs. Almost imagine it like cling film that surrounds all these organs. That's the peritoneal. And then ovarian endometriosis is also referred to as an endometrioma. And this is when endometriosis cysts are found on the ovaries or found within the ovaries, also can be referred to as chocolate cysts. And that's because of the contents, that almost like a dark brown fluid, of endometrial fluid. And then deep endometriosis. This is when endometriosis is found in locations such as the bladder and bowel. These lesions are at a deeper level when compared to the superficial or peritoneal endometriosis. So when they start, as they start to more go through into the other layers. And then extrapelvic endometriosis. This is when the endometriosis, as I said before, is found outside of the pelvis. So the thorax, which is the chest, or abdominal wall, or C-section scars. So symptoms of endometriosis. Symptoms can vary from person to person. Some may have severe and debilitating symptoms, whereas others may not have any symptoms at all. It's also important to note that the symptoms are not always related to the amount or the type or the location of endometriosis. But the most common symptoms include the following, which is pelvic pain, painful periods that interfere with everyday life, heavy menstrual bleeding, pain either during or after sex or both, painful bowel movements, so pain when toileting and passing stool, having a poo, when urinating, having a wee. And for some, they may experience difficulty getting pregnant. However, up to about 70% of those with endometriosis will be able to get pregnant naturally, so without any fertility treatment. Fatigue, so with one or more of the above symptoms, can also be a symptom of endometriosis. Many of endometriosis may also experience significant bloating, and this is usually around the time of the period. However, symptoms may not always be cyclical. So with a period, symptoms can be outside the time of the period as well. It's also important to note that endometriosis can significantly impact an individual's mental health and well-being. So it's more than just a physical pain. It can have that wider impact on a person as a whole. So just to touch on here on a condition which is separate to endometriosis, but there are a lot of similarities. You can always think of it as almost like a sister condition, which is adenomyosis. And this is a condition where cells similar to the ones in the lining of the womb, they grow found within the muscle of the womb, which is the myometrium. Again, similar to endometriosis, this condition also responds to the hormones within the menstrual cycle and affects 10% of women and those assigned female at birth. Now, you can have endometriosis or adenomyosis separately, but it can also be quite common to have both conditions together. Adenomyosis can cause menstrual pains and symptoms similar to endometriosis. Some people might describe more of a abdominal pressure and bloating, and that is because the uterus can become a bit more enlarged, a bit bulkier in its appearance. Menstrual periods can be heavy or prolonged, so periods may be lasting longer than a normal length. It can be a condition that is located throughout the whole of the entire uterus. So like you can see on these diagrams, these little bubbles that you can see in the wall of the womb like represent the adenomyosis. It can be found throughout the whole of that muscular layer, or in some cases it can just be localized to one area like a spot. So in that case, we refer to it as an adenomyoma. So diagnosing endometriosis. Firstly, it can be quite difficult to diagnose endometriosis, as we're aware with the increasing diagnosis times in the UK. And the average diagnosis time is currently 8 years and 10 months. I wish it was 8 months. And that's an average across all 4 nations. These modalities, so these tools can be used to help in the diagnosis of endometriosis, although it doesn't mean if you have an examination, ultrasound scan or an MRI scan, if these come back negative of endometriosis, so if endometriosis isn't found, it doesn't rule out a diagnosis. Okay, so an examination, it can be helpful at identifying areas of pain and potential cysts on an examination. They may be able to identify nodules on an examination or deposits of endometriosis in the rectovaginal area. So this is the tissue between the vagina and the back passage. But again, like I said, a normal examination finding doesn't rule out endometriosis. Now, ultrasound scans, this can be very helpful at looking inside using ultrasonic waves. And what we're looking at with an ultrasound scan is any signs of any endometriosis. They can be quite useful at identifying endometriosis on the ovaries, such as endometriomas. But again, a negative scan doesn't rule out that diagnosis. And an MRI scan, and it's just used magnetic resonance imaging. And this scan, again, it creates images using magnetic radio waves to produce pictures inside the body, a variety of angles to have that less invasive approach to having a look inside the pelvis without surgery. However, it's not always helpful at identifying certain types of endometriosis, specifically peritoneal or superficial endometriosis. So for some, they may need to require a diagnostic laparoscopy to get that diagnosis. A diagnostic laparoscopy is also referred to as keyhole surgery, and it is used to identify the internal organs in the pelvis in order to detect endometriosis. What will happen is, and it's an operation, so you would be, that individual having a diagnostic laparoscopy would be under a general anaesthetic. The surgeon will use a small telescope, which is called a laparoscope, and that's inserted into the body through a small incision just at the belly button. And then this connects to a high resolution monitor so the surgeon can see inside the pelvis and the abdomen. There will also be a cut dependent on the surgery, but usually on each side of the pelvis, where surgical instruments can then be inserted into the body as well, in order for them to have that clear view. So the aim is of a diagnostic laparoscopy is to have a 360-degree view of inside the pelvis to thoroughly look for any signs or deposits of endometriosis. So, managing endometriosis. With treatment, many of the issues and symptoms can be addressed or made more manageable. Now, the main treatments of endometriosis kind of fall into three categories or three sections, which is pain management, hormone management, and surgery. So we're just going to speak about each one in a bit more detail. So pain is the most common symptom of endometriosis, and pain management, therefore, is a very important part of managing this condition. Now, pain management can include using painkillers or drugs that change the way that the body handles pain. And I've just put some examples here of different types of drugs that can be used. Usually what first line, so the first recommended treatment for endometriosis would be an anti-inflammatory medication, such as ibuprofen, diclofenac, naproxen, mefenamic acid. And the reason for this is because endometriosis is an inflammatory condition, so it causes inflammation within the body. So using an anti-inflammatory medication will hopefully dampen down and alleviate that inflammatory response. Paracetamol can also be helpful at managing pain, and it can work well alongside the anti-inflammatories. For some people, they may need more of a stronger opiate medication to manage more acute flares of their endometriosis, or if the first line anti-inflammatory and analgesics aren't enough, this medication such as codeine, tramadol, in some cases morphine. Now, painkillers are used to treat acute pain may not always work as well for chronic pain. So the opiates are usually given for more that acute flare rather than for long-term use. And treatment for chronic pain can also include medications that can be commonly used as antidepressants and anti-epileptic drugs. And the antidepressants, they affect the way the body manages the pain, whereas the anti-epileptic drugs works to reduce the pain signal, so to dampen down that pain signal process that's going on inside the body. So hormone management, what we do know about endometriosis is it does respond. It's a hormone responsive condition, specifically to estrogen. So the hormones that I've got listed here, what they aim to do is aim to kind of suppress the endometriosis and the lesions and suppress estrogen. Now, there are different ways that hormone medications can be given, either as a tablet form or as an injection or as an implant or as, or when it comes to things like HRT, as patches. We can also have use a hormonal intrauterine system, which is a device that sits inside the uterus, so the endometrial cavity, which releases progesterone. So under the oral progestogens, the first line treatments would be like the contraceptive pill, so like the mini pill or the combined oral contraceptive pill. And then there's other medications which are such as northisterone, Dynagest and Provera. And you may have come across or heard of these injections called GnRH analogs. And more recently, there is a antagonist as well, tablet. And what these medications do is they almost like medically induce a temporary menopause. So they work by suppressing the ovaries and suppressing the estrogen, which almost like taking that food source away to prevent any further growth of endometriosis and to suppress the endometriosis symptoms. Now, it is important to mention that these hormones are to manage the condition. They're not curative, and they don't cure the condition, and they don't, take the endometriosis away. And then the surgical management. So there are different surgical approaches with endometriosis, and we've already discussed the role of the diagnostic laparoscopy, so to go in and look to see if there is any endometriosis. At that point, the endometriosis can hopefully be treated, and that can be done by different methods, either cut away, which is excisional surgery. So this is when the endometriosis is excised or cut away, or it could be destroyed or cut with a heat source such as ablation or a laser or diathermy, and that can also help with the cutting process to cut the endometriosis away, as well as just destroying the endometriosis lesions. A cystectomy, which is surgical excisions or removal of a cyst, is used for when there is ovarian endometriosis, so to remove that endometrioma, or they may decide to drain the endometrioma. So rather than cut the cyst out of the ovary, they can drain the contents of the endometrioma. Now, hysterectomy is the surgical removal of the uterus or womb. Salpingectomy is removal of the fallopian tubes, and an oophorectomy is removal of ovaries. Now, this is when we're going to be talking about removal of organs. This has a huge impact or definitive impact on fertility. So this is something that needs to be considered. It would only really be an option for somebody whose family is complete or they have no fertility desire. A hysterectomy isn't curative of endometriosis. It would stop somebody's periods, so the periods would stop, but there is still a potential that endometriosis could reoccur. Having the tubes and ovaries removed, so the ovaries would mean that you would go into then a surgical menopause. Dependent on what age that individual is, they may be then recommended to go on a HRT, so they were still having estrogen, because there are benefits. There are a lot of health benefits to estrogen. And then joint case surgery. So the joint case surgery will be considered when the endometriosis is affecting other organs or is found on other organs, so such as the bowel. So if there was deep endometriosis affecting the bowel or the bowel or the bladder, it wouldn't necessarily just be a gynecologist who would do that surgery. It may require input from a bowel specialist, a colorectal surgeon, or a bladder surgeon, which is a urologist. So what sometimes can happen is it can become a joint case surgery with joint specialities providing that an operation, so doing that surgical intervention. And then a laparotomy. So The aim is to do minimal invasive surgery, so laparoscopic keyhole surgery, but in some cases it may be required to do a laparotomy. A laparotomy means a larger cut, so when a larger excision, so it's not keyhole, it's where they have to do a larger incision to open up the abdomen to access the pelvic organs. A multidisciplinary team approach. So there are numerous people who are involved within patient care, and members of the MDT may include a gynecologist, endometriosis nurse specialists, radiologists. So these are the specialists that interpret the images like MRIs or scans, anaesthetists who provide that general anaesthetic and make sure it's safe for somebody to have a surgical procedure. The pain specialist, urologist, that's the bladder surgeon, a colorectal surgeon, which is the bowel, and thoracic surgeon in some cases when the chest or thorax is involved. So it's important to have that multidisciplinary team approach to ensure that the surgery is planned safely. And then there's complementary management. So there is more evidence really that's needed to fully understand the impact and benefit of complementary management with endometriosis. However, there's a lot of cases where those who have undergone these types of management options have had great benefit to their symptom management. So pelvic floor physiotherapy can be really beneficial, especially for those who have quite a increased pelvic tone. So when the muscles within the pelvis become very tense. Pain psychologists may be very beneficial for those who are struggling with this chronic, this complex pain. Diet and nutrition can also have a positive impact on those who have quite significant bowel symptoms. Some might find that there's certain triggers in the diet that may trigger off their symptoms. So diet and nutrition can be of benefit. For those who are struggling with their fertility, it's important that they discuss this and raise this with a healthcare practitioner in order to seek referral and input from a fertility specialist. Acupuncture, there's some evidence to suggest that this acupuncture, so the use of fine needles, can help in pain management. And sexual rehabilitation, so those who find sex extremely uncomfortable or painful, and working with a specialist that can really be beneficial in overcoming and managing them symptoms. And then endometriosis support. So endometriosis, it's a very complex condition, and it's important that people who are struggling with their symptoms and the condition seek support when needed. Now, GPs are usually the first line, especially within primary care. So if anybody is experiencing symptoms similar to what we've discussed, or already has a diagnosis of endometriosis and is struggling with the symptoms or needs to make any amendments to the treatment, then the first line of call would be the GP. Now, it's important to mention, although GPs are medically trained to deal with hundreds and hundreds of medical conditions, they're not all specialists in endometriosis. Some may have a specialist interest in gynecology and women's health and endometriosis. So it may be useful to ask in your GP practice if there is a GP in that surgery who has a special interest in endometriosis. Practice nurse is also a good, healthcare practitioner who will be able to provide support. So if you're going for, say, a smear screen, or you're discussing like contraceptive treatments or anything where you're having that contact, just speak to your practice nurse about your symptoms and hope they can provide you some advice, or if not, get that appointment with your GP. And with pharmacists as well. So, for pain medication, collecting contraceptive or hormonal treatments, pharmacists are trained to be that frontline support. So if you are struggling with side effects of medications, anything like that, then please do speak to a pharmacist. And then if needed, request referral to a gynecologist. So gynecologists, this is endometriosis would fit under that speciality. Not all gynecologists are endometriosis specialists. So some patients would need referring to an endometriosis specialist centre if they have suspected or confirmed deep endometriosis because of that requirement of needing that multidisciplinary team approach. If you have access to an endometriosis specialist nurse under that service, then please do reach out to them if you're needing any further support, and friends and family. So don't suffer in silence. Speak to your friends, your family, your peers, let them know how this condition is affecting you, and almost like sharing your problems and speaking to your problems with someone else can really help by offloading. Endometriosis UK. So we offer information and support to those affected by endometriosis, and we have a support network available which you can connect to, whether that be with our online community, our helpline, web chat. We also have local support groups, and we also have an very recently released a nurse support helpline. So Elsa and Zoe, they run our nurse helpline, and this is something that can be accessed via our website, where you can request a call or send an email, because we are aware that not everybody with endometriosis has access to an endometriosis specialist nurse within their NHS hospital. Okay, and I've included here just some useful resources. So we have on our Endometriosis UK website our symptom checker. Now this is a very quick, like 60-second like questionnaire where it asks you about common symptoms of endometriosis. It can be really beneficial for those who may think that they have got symptoms of endometriosis or potentially may have suspected endometriosis to complete this symptom checker. Because what it does is it records what symptoms you're experiencing. It then produces a letter, which then you can then take to your GP with the recorded symptoms and encourage them to think about endometriosis as a potential diagnosis. We also have a pain and symptom diary, so tracking your symptoms to see if there is a pattern with your periods can also be helpful. And the more information you take to your healthcare practitioner about your symptoms and any patterns that might be arising with your symptoms will only help them identify or suspect endometriosis more. And then I put links here into some guidelines. So the NICE guidelines on endometriosis have been recently updated in November 2024, and the European Society of Human Reproduction and Embryology, they have the European guidelines on management of endometriosis. And then the British Society for Gynecological Endoscopy. So this is an organisation that aims to improve the standards of treating gynecological problems such as endometriosis. It's also useful because it has a list of all the accredited endometriosis treatment centres within the UK. So you can search on there your most local endometriosis specialist centre. Okay, so that's enough of me talking for the moment. I'm going to hand over to Sophie, who has got some questions that have come through.
Brilliant. Thank you so much for that, Jo. I'm going to jump straight in with some questions. Elsa, I have a question here for you. Somebody has asked, does a laparoscopic surgery work differently for deep infiltrating endometriosis? Is the surgery more complicated?
So as you heard through Jo speaking, what a laparoscopy is, making incision in your tummy to have a look to see either diagnostic and treatment. So whatever that stage of your endometriosis, the laparoscopy process is the same. However, if someone has got very deep infiltrating endometriosis, meaning it's affecting possibly the bowel, the bladder, they call them like nodules, or the thoracic or anywhere else where it is deepened, then the surgery itself might be a bit more complex because it will take longer. And as you heard on the talk, you might need a colorectal surgeon there or a urologist or a general surgery. But apart from that, laparoscopy in itself is the same technique, just the complexity of the surgery.
Brilliant. Thank you so much, Elsa. Zoe, I have a question here for you. Someone's asked, what should someone consider when making their decision about whether they should have a hysterectomy if it is offered?
Yeah, so I think the first thing to really be aware of is that we would never say a hysterectomy is a cure for endometriosis. So if you're proceeding with a hysterectomy thinking it's completely going to cure all of your endometriosis symptoms, then unfortunately we know that's not the case. We know that it is going to take away your period, so the heavy bleeding that you are experiencing will stop. However, because endometriosis grows outside of the womb, the pain that you're experiencing might not be completely resolved by having a hysterectomy. And unfortunately, person to person, we don't know to what extent a hysterectomy will actually help symptoms in each person.
Thank you, Zoe. Joe, I have a question from you. This is from a parent whose daughter is having surgery for endometriosis. They've asked, how can we support her after the procedure and how long will recovery be? And they've also asked, if they find endometriosis, what happens next?
Okay. So lots of cuddles. Just be there, be attentive, listen to any symptoms that might be having. And straight after having an anaesthetic, they may be quite teary, emotional, and feel a bit sickly, just of the effects of the anaesthetic, which can be quite common. They may also feel quite tender, bruised, sore. So just try and keep them as comfortable as they can. Make sure you've got plenty of painkillers at home, like paracetamol, ibuprofen. Now, the recovery time it would very much depend on the type of surgery. So it can range from anything from 2 to 8 weeks. So it isn't, even though it is classed as minimal invasive surgery, there's still cuts that need healing, and they've still done quite a bit of work inside. So it's just, being patient, and just being there to support, really. And sorry, there was a second part to that question.
Yes, they asked, if they find endometriosis, what happens next?
Okay, so I guess that depends on whether the endometriosis is treated surgically at that point. So if it's just a diagnostic laparoscopy, so if it's diagnosed and not treated, there may be some discussions about potential further surgery if that's something that individual wants to opt for, or they may discuss the other treatment options such as looking at pain management or hormonal treatments.
Brilliant. Thank you, Joe. Elsa, I have another question for you here. Somebody's asked, is hormonal therapy, so things like the contraceptive pills, usual treatment for treating endometriosis before going in for surgery? And how does this kind of treatment work?
So it can be used as a treatment option itself and not necessarily prior to surgery. So the hormonal treatment, as also mentioned on the webinar, can be the pill combined or the mini pill, which they work slightly different. One totally turns off the ovary and the other one just dampens it down. Could be the Mirena coil, which also is similar to the mini pill, or it can be the analogs that Joe mentioned. So for some women, one of those treatment might be enough. And as long as it works, depending on their symptoms, that's fine. For others, it might be used while they are awaiting surgery because the symptoms are so bad that they need surgery. But in the interim, while they're waiting, they will use it. And was there a second part?
And it was, how does this kind of treatment work?
How does the hormonal treatment work? So
Yeah.
again, the combined contraceptive pill, basically you produce estrogen from your ovaries, and this is what the endometriosis feed on. So when you're given that, it's encouraged, providing, depending on your age and depending on medical history and your symptoms, you're advised to take it back to back. So you don't have a break, you just continuously take it. And obviously your nurse or your doctor will discuss with you if you get, say, like breakthrough bleeding, what to do. If it is the mini pill, your body's already producing progesterone, so you're given extra, so that together dampens down the ovaries from producing as much estrogen. And sometimes there is side effects, i.e. you might get erratic bleeding until the whole lining is shed and is settled. So it all depends on which one you go on, but the whole idea is to reduce the estrogen in your system, so that reduces the growth of the endometriosis.
Brilliant. Thank you, Elsa. Joe, I have a question here for you. Do we have to be on a contraceptive pill to help our condition?
No, you don't have to be on a contraceptive pill. Contraceptive pills are not suitable for everybody. There's lots of things to consider. If somebody is actively trying to conceive, we definitely wouldn't want to be putting them on a contraceptive medication because of the contraceptive effects. So when I say wanting to conceive, is in like trying to get pregnant. Also, there may be some medical reasons as to why you might not be able to be on a hormonal treatment. You know, certain conditions, or if there's been breast cancer, blood clots, there'll be certain medications that they may want to avoid due to associated risks. So no, you don't have to be on a contraceptive medication. And it's also important to mention that not all the hormone treatments are licensed as contraception. So even if they was on a medication such as the GnRH naloxone injections I discussed earlier, which like switch off the ovaries, they're not actually licensed as a contraception, but you'd be advised not to try and conceive, so to use like barrier methods while you're on those types of treatment.
Thank you, Joe. Zoe, I have a question here for you. Somebody has asked, what is the likeliness of endometriosis returning after excision surgery of all the visible endometriosis and a Mirena coil being inserted?
Yeah, so we don't know person to person. We know that in some people, endometriosis can be progressive, meaning that it can grow back or it can progress. We also know that some people will have surgery and it won't grow back. We don't know why, we don't know the rates, and we don't know why that varies person to person. In terms of having the coil put in, you know, when we think about the fact that it's a way of hopefully preventing the growth of endometriosis coming back. We can't be sure that 100% that it won't cause and won't stop complete regrowth.
Thank you, Zoe. And it kind of ties into my next question for Elsa there. If endometriosis is removed by laparoscopic surgery, is there a way to prevent the endometriosis returning without hormonal contraception?
So like Zoe says, it's very difficult to say for each individual. And there's many women who will have surgery and that will be it. And there's also many women who, unfortunately, for various reasons, say, for example, if there were spots of endometriosis that couldn't be treated at the surgery, that might grow as well. Repeat the other part of it for me, please.
They ask, is there a way to prevent endometriosis returning without hormonal contraception?
So you can't necessarily prevent it, and we don't have a cure, but there's things that women can do to sort of help reduce the chances of it. And for some women, that's quite effective. So your lifestyle changes. There is not great evidence out there, but they're doing more and more research. So look at things like your diet, because that might help with your symptoms. So because, as we already know, it's an inflammatory process, let's talk about reducing things that increase the inflammation. So some people will look at reducing dairy products, reducing red meat, sort of practicing more of a Mediterranean diet, reducing alcohol if you drink. We're not saying stop everything, but cut them down or reduce them. And wheat seemed to be a big thing that creates bloating and create other issues, so maybe gluten-free as well. And exercising, I know when you're in pain it's very difficult, but walking or maybe doing stretchy exercises, anything that will help you manage it a bit better, because when you exercise, you also produce another type of hormone or endorphins that just make your body feel better. Get some rest, sleep, and plan out your day and manage it, as opposed to when you feel well, you do everything, overexhaust yourself, and then you end up having more issues. So yeah, these things will help, but there's no guarantee it will stop the endometriosis ever recurring.
Thank you, Elsa. Joe, I've got a question here for you. Does endometriosis only grow during a period, or does it grow throughout your cycle? If not, how can we explain an endometriosis flare-up?
Okay. So endometriosis, if we think about like the hormone treatment, so trying to stop a menstrual cycle and stopping periods, unfortunately for some, even if they're on a hormone treatment, there can still be some growth or progression. So it's not necessarily always growing while you're on a period. What tends to happen is the symptoms can become more intense or flare when somebody's having a period, and that's because the endometriosis becomes more active because of them hormonal changes. So we said before about the how it responds to hormones in the menstrual cycle. So when you're having a period, and if you think of the lining of the womb, these are kind of like the swelling, bleeding, becoming more inflamed. A similar process is going on inside the pelvis. So that's usually why people have more of a flare around the time of a period, because of them changing the hormones and the menstrual cycle.
Thank you, Joe. Elsa, I have another question for you. Somebody's asked, if you're given a stage of endometriosis diagnosis, such as stage 4, but it is exercised during surgery, do you still have stage 4 endometriosis?
So if you're given a stage, which is very much an Americanized staging, so here they tend to more say a mild, moderate, or severe stroke deep infiltrating endometriosis. If you've had a laparoscopy and treatment and it's excised, once you've had that done, no, you don't have that same stage anymore. However, your endometriosis may recur or it may not. So that's why whoever your specialist is or your nurses are will discuss other options with you post your laparoscopy treatment.
Thank you, Elsa. Zoe, I've got a question here for you. How would you get a GP on board with the management of the condition when they pass you on to services like gynecology?
Yeah, so I know this is incredibly frustrating, and I've had a read through the comments as well. And I know there's many people here who are feeling that kind of exhaustion of constantly going for appointments and constantly feeling like they're not being heard. I think it's really important that you are ongoing tracking your symptoms and pinpointing the things that are causing you the most impact to your day-to-day life, and work on one thing with the GP. We know that unfortunately GPs are not, in most cases, not specialized in endometriosis. However, if you are constantly going and saying, my pain is not managed, and that's the one thing that's really impacting your daily life, ask if they can use other services. Like, can they refer you to pain management? Have they referred you to pelvic health physio while you're waiting for gynecology? And try and keep that communication going, and where possible, try and make the same appointment with the same GP, so you've got that continuity of care. It's also really important, and I know sometimes it's a lot of like medical jargon, but looking at the NICE guidelines and understanding what care you should be receiving. And if you feel like you're not receiving that care, take someone with you to your appointment and say, you know, this is what the standard of care is. I don't think these things have been done for me. You know, can you support me with this?
Brilliant. Thank you so much, Zoe. Joe, I have a question here for you. Why does bloating happen to such an extent that I look heavily pregnant? And is there anything that helps this bloating?
Okay. Yeah, so if you remember of the symptoms I listed earlier, bloating can be quite a troublesome symptom for many with endometriosis. And as we know, it is an inflammatory condition. So if you think of your bowel as this big sausage and big like wraps around everywhere in your abdomen and pelvis, it's in very close proximity to your uterus, the ovaries, the reproductive organs. And this is why the bowel can become affected by endometriosis, because it's in close proximity. The bowel is a sensitive organ, so things can make it a bit sluggish, so move slower. That can be the inflammation process because of endometriosis. It can also be hormonal changes. So either, people without endometriosis can get some bloating during, before a period because of the hormonal changes that happen. But then if you're adding in the inflammation process, which we experience with endometriosis, and that can just make it worse. So things that can help with it, as Elsa mentioned earlier, like avoiding foods that create inflammation, so like an anti-inflammatory diet, like similar to the Mediterranean diet. Peppermint tea can help some, and moving. So just like encouraging exercise. Not only does that help with the endorphins, but it helps with like keeping the bowel moving as well. So yeah, it's a few tips.
Thank you, Jo. Sorry, I've got another question here for you. Is there any guidance about how you can manage your endometriosis through diet and lifestyle changes?
Yeah, so I think obviously what Elsa and Jo have touched on, the Mediterranean style diet in terms of thinking about inflammatory foods is really key. In terms of clear guidance for everybody, that we just don't have that. What we know is that inflammatory foods could impact the inflammatory response in the body. We know endometriosis is an inflammatory condition. So, when we put the puzzle pieces together there, we hope that that would then improve people's symptoms. In terms of categorically saying every single person should go gluten-free, we don't have that data. However, it's a good thing to trial if you are getting things like the bowel symptoms and the bloating, and you're finding that you are feeling like you're looking pregnant at certain points in the month. They are good things to trial, and we always say try and do things periodically. So don't try and go and do every single thing at once, because when you're trying to also manage a chronic condition alongside bleeding very heavily, feeling fatigued, and then having to cut out all the enjoyment out of your diet is just not possible. So try and do things little and often. And I will just say one thing I've just seen in the chat is, how can you access the services in terms of nutrition and dietitians? Is extremely difficult, and we really do understand that, and we know that not everybody has access to that. So how you can do that, you can either speak to your GP and see if they know of what the dietitian network is like within your area. You can also speak to, if you are part of a hospital that does have an endometriosis specialist centre, see if they have connections with the nutritional team or the dietitian. But actually, we did a really, really good webinar, didn't we, with a nutritionist and a consultant who gave so much helpful advice. So I definitely recommend going and watching that.
Brilliant. Thank you, Zoe.
Can I just add something to that as well? So so the webinars, they can be accessed on our website. And keeping in with what Zoe was mentioning, the pain and symptom diary, which I referred to earlier on the presentation, can also be useful for seeing if there's any triggers in your diet. So if you're noticing if there is any triggers, that might be flaring off any symptoms, you can always keep a bit of a food diary as well, alongside that pain and symptom diary, to see if you're noticing if there's any triggers, and then try cutting or reducing them food groups.
Thank you both. We've had a few questions around the causes of endometriosis, and what's cropped up a lot in the chat and in the pre-submitted questions is endometriosis genetic? I don't know. I don't mind who'd like to answer that.
Yeah, I can answer that question. So in the updated NICE guidelines, so the national guidelines which I referred to earlier, they updated them in November, and that now includes asking, so as part of that screening, taking a history of a patient, is asking if there is a family history of endometriosis, because it is believed to be linked to an increased likelihood of you being at risk of having endometriosis. So there is that link there with genetics and family history with endometriosis, and it should be considered now as part of that referral process.
Brilliant. Thank you, Jo. I'm going to move to some of the live questions now. We've had a few people asking about the referral pathway and how they can access a specialist centre or specialist nurse. So what does that process look like? I'm not sure who would like to answer that.
Initially, sorry, Jo.
No, go on, Elsa, I'll let you speak.
So I was going to say, if you've got symptoms or you're not sure and you're suffering from all these pain or heavy bleeding and other symptoms, the ideal thing is to see your GP. And we do know sometimes it's difficulty with appointments, but you need to get your GP to do a referral for you, or someone else from the multidisciplinary team. If you're already under another hospital, for example, and they're general gynae and you've got endometriosis, they can also refer you. So there are, if you go on the BSGE website, they will tell you the list of accredited centres within the UK. And the accredited centres basically mean there is no specialist. There's usually at least a minimum of 2 consultant who specializes in endometriosis. There will be colorectal team, a urology team, and they'll be linked to pain management team and radiologists. So it's got the whole list there. So the idea is whatever your endometriosis, especially if it's deep infiltrating, then the whole team, as Jo mentioned, can have multidisciplinary team meeting and discuss with you the best treatment option. So you need a referral into one of these accredited centre, and then they will take it from there. Prior to that, then GPs can initiate sometimes to get you have a transvaginal scan or MRI imaging, and they can start certain treatment under NICE guidelines, but that is the best option, is to get referred into a centre.
Thank you, Elsa. We've had someone ask, why can MRIs and ultrasounds detect some cases of endometriosis but not others, as this person had several of those scans and it showed nothing until they had their surgery?
So MRIs and ultrasound scans, they can be really helpful in that diagnosis process, and they can also be really helpful for surgical planning. So it can kind of give an idea of what's going to be expected when they do that procedure, again, so they can safely prepare for that operation. So the scans can be really helpful at identifying ovarian endometriosis. So when there's cysts that are on their ovaries, that can be quite clearly seen on both MRIs and ultrasound scans. You can also see signs of like adhesions, or there's just where the tissue is almost like pulled together. So like because of scar tissue. So you might not necessarily see nodules or deposits of endometriosis on a scan, but you can see the signs that would suggest the likeliness of endometriosis. But again, it can sometimes be the case that when you actually then go and have the diagnostic laparoscopy, that's when you're going in physically with the camera. They may even see more extensive endometriosis than they've seen on scans. Now, an MRI and an ultrasound scan isn't that sensitive at identifying the superficial endometriosis. So if there are more like dots of endometriosis just on the surface, there's not always the signs of scar tissue or adhesions or the nodules that you can pick up on a scan, because it's just not that sensitive. So that's why it's important to know that just because you've had a negative scan, if you've been told there's no endometriosis on this scan, everything's normal, it doesn't rule out a diagnosis.
Thank you. I've got someone asking, how long do you have to wait to know whether or not a contraceptive pill like the mini pill is working?
Yeah, so we'd normally say if you can tolerate it for 3 to 6 months to really see the full benefits and see if it is something that is going to help and improve. But obviously, we completely appreciate that if you are getting severe side effects, that's not always appropriate. So if you are concerned that things are not sitting right with you and you're not feeling well with it, do make sure that you are having regular communication with the person that's prescribed that. So making an appointment with your practice nurse or your GP to discuss the side effects that you're getting, and not just, putting up with them. But we would say 3 to 6 months is the ideal.
Thank you, Zoe. We've had a few questions about endometriosis and menopause. So some people asking, does endometriosis continue to develop during peri and post-menopause? And does menopause cure endometriosis?
So endometriosis, it can still be troublesome for some after the menopause. And the reason for that is because of the complexity of the condition. So if there is scar tissue and adhesions in the pelvis, or if somebody has then developed more of a complex pain condition because they've been living with pelvic pain for a long time, these nerves can sometimes become quite oversensitized in the pelvis. Even when the endometriosis isn't active, so when somebody goes into menopause, your ovaries switch off. You're no longer producing the estrogen that kind of feeds this condition. So even if the endometriosis isn't active, the effects of having endometriosis can still be, for some, troublesome post-menopause. But for many, they do notice that improvement in their symptoms because their endometriosis is inactive, and it can also kind of almost like shrink down, so like regress, because it's no longer active and it's not got that hormone switch which it's responding to. It may be the case because obviously if somebody is in the menopause or perimenopausal, the question you might be thinking is, what will happen if I need HRT? Because HRT contains estrogen. So the reason why people people have HRT is because of the effects and the symptoms of the menopause, because of having that no longer producing the amount of estrogen that was produced beforehand in the perimenopause or when the ovaries switch off in menopause. So yes, you still can have HRT if you have endometriosis, but it may be recommended that you have a combined HRT. So not even if you've still got, even if you've had a hysterectomy or you've had quite extensive surgery, there may still be a recommendation that you have a combined HRT which contains progesterone, like a progestogen, to help keep any endometriosis suppressed while you're having that estrogen to help with the menopausal symptoms. But yeah, it's a myth that the menopause completely gets rid of all endometriosis symptoms, because endometriosis, unfortunately, is quite a complex condition.
Brilliant. Thank you, Jo. I believe that is all the time we have for today's questions. I know there are still a few questions in the Q&A box, and we will pass those on to Jo following this webinar. If you do have any other questions, you can email us at support@endometriosis-uk.org. And as Jo shared earlier in her presentation, we do now have our new nurse-led helpline, so you can visit our website if you would like to book an appointment and a phone call via that. I'd just like to say thank you so much to Jo, Elsa and Zoe for today's webinar, and to everybody who joined us today and submitted their questions. There will be a survey at the end of this webinar, and we kindly ask that if you have the time to please complete that survey for us for our future webinars. Zoe, Jo and Elsa, are there any sort of closing remarks you'd like to share with everyone watching today?
Thank you very much for joining. And I hope that it has been of use, and please do make sure you speak to somebody if you are experiencing these symptoms.
Yeah, thank you, everyone. Yeah.
Same. Thank you.
Brilliant. Thank you, everybody, and have a wonderful evening.